So this is really, interdisciplinary collaborative panel consisting of transplant nephrologist, a hematologist, oncologist, as well as a pathologist. We all see the clinical knowledge gap in transplanting patients with a myeloma or AL amyloidosis, patients with plasma cell dyscrasia in general. And as a part of the American Society of Transplant Onconephrology work group, we put together this extensive, comprehensive panel, and we started to work together.
I think that really the most important change has been the hematologic response rates. So in the past, our most powerful drugs had a response of 50% and a complete hematologic response in the 10s to 20% range. And now we're seeing almost quadruplet therapy, or even in the relapse setting, we have response rates that are up to almost 80 or 90% or higher, with complete responses even in the 60 to 70% range. And just getting better and better. So that means that the hematologic disease can be controlled adequately, both in the upfront and the relapse setting, such that we're less concerned about relapse or graft failure in patients with these diseases. The patients used to live, the median survival was 5 years, even in myeloma. Now the median survival is upwards of, projected in the most recent studies to be over 10 to 15 years and growing. Really, it's the hematologic response biomarkers, being able to not detect the clone, MRD. We have a new measurement, whereas we never even got to complete hematologic response, even serologically now, because patients are getting these deep response. We have these MRD negative bone marrow assessments that show that even with our most sensitive methods, 10 to the minus fifth and 10 to minus sixth, we can't detect any disease. And then the other component that's important, especially in the myeloma population, is the cytogenetics, which really have prognostic information. So that tells us it's not as important in terms of who's going to respond, but how at risk the patient is of relapse. That's in the myeloma population. In the amyloid population, we also have measurements of cardiac involvement and extra kidney involvement, but those are difficult to interpret in the setting of end-stage kidney disease.
So this is a very difficult question because, these patients with a plasma cell dyscrasia, especially myeloma and AL amyloidosis, they are at the higher risk of infection. So to begin with, even prior to the kidney transplant. And the risk of infection is higher after kidney transplantation once they're on immunosuppression. So we need to carefully manage the maintenance transplant immunosuppression. Some experts suggest decreasing the antimetabolites, for example, mycophenolate or azathioprine by half, but there's no study to support or support this strategy. So we need more study to do this, but I think it's a good start to give some guidance, in terms of the immunosuppression management. And the transplant medication consists of two parts. One is the induction therapy that patients receive in the very beginning of the transplant, and the maintenance therapy that a patient to be on for lifelong. So induction therapy, again, there is no guidance at this moment, but some people may suggest we should or may need to use a less potent induction therapy just to prevent the increased risk of infection in the future. So these are kind of two suggestions that we made in the clinical guidance paper, but more research is needed to support that guidance.
I think we have limited data to guide us. So I think we all investigated together what the literature supported and then shared our protocols and our standards of care with one another. And it was really a collaborative effort looking at, what's done at each center and come up with the best recommendations based on a collaborative experience in addition to what is already published. And making with the caveat that we were very well aware that there's more questions than definitive guidance on how to proceed in this way. But the fact is that these patients should not be excluded from kidney transplant in this day and age. And we wanted to provide a framework for hematologists and nephrologists and transplant nephrologists to start, not wait for the data because the patients can benefit from this therapy now.
So some nephrology or transplant center has, already embedded collaborative clinic on site. For example, the hematologist and oncologist working side by side with a transplant nephrologist. That would be ideal, but not all centers have that luxury to do so. So I think being aware of the each other's availability and try to communicate by, the chart messaging and so on to exchange ideas and thoughts will be a good start.
The point is that I don't think that all these research questions actually need to be answered because I think that patients will benefit now. Keeping patients on dialysis is not the best approach. So, but I do think that we can optimize the way that we do transplants, what medications can be used in the maintenance setting, for instance, or in the setting of a relapsed patient who's getting T-cell redirecting therapy, how to navigate that situation, as well as the induction issues that Dr. Murakami already suggested, and what level of as we learn, the depth of response really matters and in whom it really matters. There's some patients where it does really matter in these high-risk cytogenetic patients that they need to be in a very deep response, whereas there's other patients who go who can get a VGPR and still have a good outcome with kidney transplantation.
As Dr. Landau mentioned, that keeping the patients on dialysis is not the option, for those patients with a plasma cell dyscrasia who can do better on after the kidney transplantation. So as we emphasized in the paper, the goal here for the patient with the plasma cell dyscrasia to receive a kidney transplant is to have the longest off dialysis time and for them to have quality of life off dialysis. So myeloma is really a marathon. It's not the, like a short-term, done deal after therapy. So we need to take the patient journey together to think through how to manage the kidney dysfunction as well as the maintenance of immunosuppression and the maintenance of myeloma or amyloid therapy together collaboratively. So I think we like to emphasize that patient, you know, share decision making and having the journey together with the hematologist and transplant nephrologist the most important.
I would just add one more thing or two more things actually. So, in the community, sometimes this is an unheard of concept. And I just want to emphasize that patients or nephrologists who are confronted with this can easily send their patients to more experienced or specialized centers who feel more comfortable with this so that they can be evaluated. At, really, and it's never too early. Let us decide, let uh, the specialists decide when that should happen. So if a patient presents with end-stage kidney disease, there's no definite time frame. It's not like another solid tumor where we say, oh, they have to be in remission for 5 years. It's actually quite the opposite. So we do have some guidelines with respect to timing, but at least have the conversation early so that the patients can benefit as soon as possible. The second issue I just wanted to say, it's really a different landscape these days with the directed donor or the living donor kidney transplant. So, it's different. You're not taking a kidney away from a healthier patient per se, when there are, not infinite resources, but there are several resources available to these patients where it can be a very planned procedure, which makes in somebody who's receiving plasma cell directed therapy very controlled and very accessible.